So we're going to talk a little bit about value-based care today, and very specifically, I want to kind of ask the question, should my healthcare organization accept a value-based payment opportunity? Or let's rephrase this a little bit and kind of make it more personal. If I'm offered a value-based payment contract, should I sign the thing? Or the corollary might be, if a value-based payment system is forced upon me, what should I have done to prepare for it? So we'd like to kind of keep those two considerations in mind as we go through this presentation. Let's start first with something that I think is very important, and it's the triple aim. And the triple aim, for those of you who are not familiar with it, suggests that the healthcare system should deliver better patient care. And by better patient care, I mean quality of care, patient safety, and the experience of healthcare. It should deliver improved community health, and it should use our hard-earned dollars wisely. Now, this concept came from Don Berwick, who was the president and CEO of the Institute for Healthcare Improvement. He's probably the most famous, and appropriately so, quality improvement expert in the world. He's actually been knighted by Queen Elizabeth for his work, and he had a very short stint as a director of a CMS. So we give a nod and a thank you to Don Berwick for all the work that he's done over his career promoting quality improvement in healthcare and promoting the triple aim. And the triple aim tends to lead to this pretty simple mathematical expression. And I'm not a mathematician, but I can add and divide, I think. And I came up with this equation back in 2006, actually about 2 years before the triple aim was released. And I was asked by a group of hospitals in northern Michigan, the UP of Michigan, to talk about healthcare reform. And they kind of want to know, why is all this nonsense of healthcare reform being forced upon us? And I argued at that time, it's because we're not delivering the value that we know we're all capable of. So my simple equation of healthcare value is quality plus the experience of healthcare divided by cost. But we have a problem, don't we? And that problem is we're not getting paid for this. This isn't part of the way we're paid. And we might kind of quote Churchill, even though I'm not really sure that he said this, but it's kind of appropriate here, that you can always count on Americans to do the right thing after they've tried everything else. And it's really apropos in healthcare. So here's what we've tried everything else. So fee for service. Now let me take a look at this from a patient perspective. Fee for service. I pay my doctor more, the more he or she does to me, whether it helps, hurts, or does nothing for me. Now, does that make sense? No. How about capitation? Let's switch it around. I pay my doctor the same, no matter how hard he or she works for my good health. That doesn't make sense. Well, how about the market? Well, we're sitting at about a healthcare cost right now in the United States of about $3.5 trillion. There is nobody on this call, me especially, who can actually conceptualize what $3.5 trillion is. It's like dollar bills going to the moon and back several times. So I'm not sure the market has really served us, and particularly not served us all that well in rural America. And although there may be some advantages around efficiency in a single payer really doesn't get us to value on its own. So I'm kind of wondering about, shouldn't the healthcare system pay for healthcare value? Isn't that what we maybe all would want in the system? So I made it the kind of concept of value in that equation really way more simple than it really is. So please allow me a little bit of latitude to try to make this concept, which is really very nuanced, a little bit understandable for people like me. Value is more than just the triple aim. It's more than just a quick equation. You might even ask, what is value? Is value a noun? Or is it a verb? Do we provide value, or are we value oriented? And whose perspective are we talking about here? The perspective of patient, physician, employer, taxpayer. CMS leader is all very different when you talk about value. And I gave you kind of 3 components of value. How do we prioritize those? Is quality more important than cost control? Is the patient experience more important than quality? There's no simple, easy answers to that. But let's not let perfect be, let's not let perfect be the enemy of good, because it often is. And I'm going to argue that I think this volume to value transition that we're undergoing now should continue. And it's my job today to help you all understand some basic concepts of healthcare, of value-based care, and value-based payment. Now, before I talk about payment for just a second, let me pause for a moment to talk about why I think payment is important. And you might say, why is this physician talking about payment, for crying out loud? Well, it's not because money makes the world go round. It's not because money is the manifestation of some hospital leader's command and control. It's instead because payment is what allows us as a healthcare organization to deliver the essential services necessary for our patients, for our communities. That's why it's important. And value-based payment requires value-based care. It requires that. So value-based payment is payment for one or more parts of the triple aim. It is not a payment for a service. Therefore, it's not fee for service. If we think about that word fee for service, we toss it around all the time, but it's actually a payment for a widget. It's a payment of widget like a CAT scan or a knee x-ray or a complete blood count. It's not payment for a fee, not for an individual service. It's not fee for service. And we've got 8,000 plus services in healthcare right now. I also want to parenthetically say that as we talk about that value equation, there has been a historic emphasis on cost reduction. And we used to say among the prior administration that the triple aim was cost reduction, cost reduction, cost reduction. And then we kind of hoped that better care and improved community health would tag along. To be honest with you, with a $3.5 trillion healthcare bill in the United States, which is twice as much per capita as almost any other country in the world, I don't think that that emphasis is going to change too much with the new administration. And maybe that's okay. But let's us, as hospital leaders in rural communities, think about how payment systems can help us deliver the care our patients need. Now, in continuing with that concept of payment, I want to kind of express a truism. And the truism is form follows finance. You know, somebody cuter than me has kind of said, follow the money. But how we deliver care, how we deliver healthcare depends on how we're paid for care. Now, this doesn't mean that all hospital CEOs and physicians and nurses are charlatans out there to milk the system and rob our patients. But also it does mean, though, it's very hard to get an organization to survive while it's bucking the financial trends or the financial requirements of the system. And in a fee-for-service system in which we predominantly operate, the trend, the movement is for volume. That's how the organization survives, is with volume. And we might want to ask ourselves or ask our good friends and family, is that really the way we want our healthcare providers to be paid? Well, I think a lot of us say no, it's not. So as we start to think about payment reform starts to kind of move where risk lies, financial risk lies, from the payers to the providers. And as we start to think about this transfer of financial risk to us as the hospitals, as the physicians, as the providers, requires a cost benefit analysis or a risk assessment. Now, it's really important when I talk about risk does not imply good or bad. It doesn't imply positive or negative. It's instead a likelihood of change. But what we tend to do when we talk about risk is we tend to talk about risk versus benefit. That's not really correct, but even I kind of do that. So when we think about risk, think about risk as the risk for financial success, the risk for financial distress. But forgive all of us for kind of talking about risk in a negative way. It's not necessarily. So I want you to consider a risk continuum as we think about these new ways of getting providers paid. Over here on the left, we have high payer risk, fee for service. Doctors and hospitals can increase volume. They can induce demand based on what economists would talk about, and that becomes at risk for a payer. So that's fee for service all the way over to the left. And total cost of care is where a provider or a system, a healthcare system, is paid one set fee to take care of a community. Total cost of care. I'm going to talk about two of these along the way here as kind of examples of this movement from high payer risk to high provider risk, from fee for service to total cost of care. So let's talk about those just a little bit. Accountable care organization. An ACO is a group of providers, generally physicians and or hospitals, that receive a financial reward to maintain or improve quality, that's important, for a group of patients while reducing the cost of care for those patients. This is CMS's largest value-based payment program, their ACO program, or in Medicare terms, it's called the Shared Savings Program, or SSP. There's over 1,000 of these organizations, ACO organizations in the country, serving over 333 million enrollees. You know what? That's 10% of the population. And from a Medicare perspective, 477 Medicare ACOs are 30% of the Medicare fee-for-service beneficiaries. That's a lot of people. So this is a big movement, and it's important that you all know a little bit about ACOs. Well, in an accountable care organization, cost savings and quality performance are required. And if CMS, in this particular case, or Medicare, realizes some savings that you're providing them, they'll share some of that money back with you. A couple of important points here. The quality measures that I'm talking about are outpatient quality measures. Now, you'd think I'm talking to hospitals, but the key here is the quality is delivered by physicians and primary care practices, not hospitals. And it's important also that patients, at least currently, except with some exceptions in current models or demonstrations, patients come into your ACO through primary care use. So that behooves us to pay attention to what's happening in the outpatient world of our health system in our rural communities. Now, this is how it works kind of financially. Let's just assume for a second that Medicare is currently expending $10,000 on a typical Medicare beneficiary. That number is probably not too far off. And the ACO accepts that particular beneficiary into its ACO, and it starts providing ACO-like care. It provides care coordination. It starts sending patients to cost-efficient specialists. It cares for patients not in the emergency department, not hospitalized, but instead as outpatients or even in the home. And at the end of the year, let's just say that all of the care provided to this particular patient now is only cost $9,000. We've got a $1,000 delta here. We just saved Medicare $1,000. They did not pay a provider that $1,000 this year because of the work you did. So there we have the $1,000. Now, the one thing in ACOs is the house always wins. so they're only sharing 50% of that $1,000. So where do you say, where's the other $500 go? Well, it goes back to Medicare. But they share with you, they actually write the check to you for $500 at the end of the year. Now, wait a minute though. We had to do that quality. And if your quality is pretty good, but not perfect, they're going to adjust your payment down, in this particular example, $450. So in the end, we had a $450 payment for an ACO, but we actually ended up charging Medicare overall, hospitals, clinics, everywhere, $1,000 less. So here's some benefits for participating in an ACO. Well, this is a toe in the water. This is a way to get started. It's a learning opportunity for managing population health, managing financial risk, and it's relatively low financial risk, relatively low. As we've talked about in the past, and Eric and I talked about this not too long ago, one of the neat things about ACOs, Medicare ACOs, is they give you the data on where your patients are receiving care, whether it be in a town next door or in Fort Myers, Florida, when your snowbirds go from Minnesota or elsewhere. So in any event, you get the data, and then you can help kind of prioritize where these patients should go based on, one, quality of care, but also cost of care. And it's almost always better to care for those patients in your own home organizations, if at all possible. Now, ACOs are still a fee-for-service platform. I told you that Medicare calculates how much it costs to deliver care for a Medicare beneficiary at the beginning of the year, and they calculate it again at the end of the year. But during that entire year, you and every other provider that sees that patient of yours is getting paid fee-for-service. It is volume-driven. But the key here is for the ACO to shift care to less expensive providers like home health aides or community health workers or primary care providers. That's much less expensive than a hospital stay or an emergency department visit. Now, there's some risks here. It does require some upfront investment. It requires, if you're not buying into a ACO consolidator like Caravan, a Caravan does have a monthly charge, but if you're doing it on your own, you need to develop the capacity to care for a population. You need the capacity to manage financial risk. And I believe that this is R&D. We don't think in healthcare about research and development, but we should. And we need to kind of figure out the right amount to spend in R&D that does two things. That avoids two things, excuse me. That avoids navel gazing, that you're doing nothing, hoping that this value-based care movement will just pass me by. That's inappropriate. It's also inappropriate to burn through your reserves on something that's yet untested and incomplete. So you as hospital leaders need to find the sweet spot for research and development between doing nothing and burning through all of your reserves. There's also what's called downside or shared risk is becoming increasingly prevalent. Now, in most of ACOs right now, if your patients overspend, so instead of dropping down to $9,000, a patient goes up to $11,000, you're not responsible for making up that difference of $1,000, but that's kind of going away. So increasingly, we will be on the hook as providers for excess expenses as well as realizing shared expenses. I wrote here, as part of the upfront investment, that value-based care requires financial risk management, population health management, and data analytic capacity. And I want to emphasize again that even though hospitals actively participate in ACOs, primary care engagement is critical for success. Quality is being measured in the outpatient's primary care office. Patient attribution to your ACO comes through primary care visits. And even though sometimes physicians will deny this, they have a very powerful influence over patients on about where those patients should receive care. I've been reading recently about patients actually choosing higher out-of-pocket cost care, simply because that's where their physician recommended. You'd think the patient's going to say, I want to go to the place that costs me out of my own wallet less than some other place. They often go where the physician suggests. So why don't we suggest as physicians or primary care providers, those specialists or those rehabilitation units that provide the best care at the lowest cost? Now, let's switch over to global budgets. So global budgets are not as prevalent. We have global budgets going on in demonstrations in Maryland right now and in Pennsylvania. I work quite closely with the Pennsylvania Rural Health Model. So I want to tell you a little bit about what a hospital global budget is. So a global budget is where the hospital's paid a fixed amount of money per time period. Think of it as you get a pot of money at the beginning of the year. It's not quite that, usually it's per month, but think of it as a pot of money at the beginning of the year, and Medicare says, go forth and do good work. Serve your community, but don't overspend your pot of money. That pot of money does not vary by the number of services provided. It's not fee for service. But what's cool about this concept in theory is it starts to allow us as clinicians, as hospital leaders, to start thinking much more pragmatically about health maintenance instead of illness treatment. How many times have you all heard that we have a sickness system in this country, not a health system? It's true. It's true. We're paid for treating illnesses. We're paid some for preventing illnesses, but in comparison to illness treatment, not even close. So we do have some models existing right now. I have mentioned the Maryland Total Cost of Care model, the Pennsylvania Rural Health model that I work with, and then the pending Community Health Access and Rural Transformational Chart model that is pending, that hopefully will get started later this year into 2022. So here's why global budgets may make sense to some hospitals. If you are honest as a hospital leader or a hospital CFO, and you're looking at your revenue over time, hospital revenue, and we'll use Medicare, but right now in Pennsylvania, it's all payers. It's Aetna, and it's Blue Cross Blue Shield. It's all payers. And if you say, now looking back, my trend in revenue is going down because one, inpatient utilization is less over time. It's actually, it's falling right now, or your population is declining, or you're finding that your population is traveling farther for their healthcare, and you're seeing your trend going down, that's unsustainable. Eventually, you're not going to be able to keep up with that. And this is exactly what happens when hospitals go bankrupt and or hospitals close. So if you are offered a global budget, and I'm just using my line here at 2022, look what happens to your revenue. It stops declining. It's maintained. So for hospitals with a declining hospital revenue trend, and you are honest and think that trend will continue, global budgets can be a lifeline. One hospital CEO told me in Pennsylvania, this gives me financial breathing room, having a global budget. He was seeing his trend going down, and he knew what was going to be happening. And he knows that there's no free lunch, that pretty soon insurance companies are going to want to pay cost of production. But he says, this gives me some financial breathing room until we get this sorted out. So I'm arguing that this global budget, if you were offered it, is appropriate if you have downward revenue trend, declining population, or you're a financially distressed hospital. It's likely not appropriate for organizations with upward revenue trend. But I want to emphasize this bottom bullet, and that is when you're doing these assessments, you need to be candid. You need to be honest. You know, I got to admit, I've almost hardly ever met a hospital CEO that doesn't think his or her managerial or sales acumen is going to drive market share to their hospital, and we are going to save the day through great leadership and great management. You know, for about 120 or 30 hospitals in this country over the past few years, that just hasn't been the case. There are economic and demographic realities that we are up against, and until the payment system changes away from fee-for-service, as long as we are dependent upon volumes, there will be hospitals that will not be able to continue. So as you think about those questions, it does, that I posed at the very beginning, it requires some very candid thinking about what's happening in your hospital and in your community. So what are the risks of this? Well, one risk is your volume goes up or your costs go up. Well, that isn't really what we want because we're locked into a revenue. It does lock in your historic revenue. And despite doing that, reducing costs isn't really easy. To reduce costs is difficult. And as we look to the future, how your budget is going to be adjusted are still unknowns. And you may like to think that we can kind of get rid of our billing and revenue cycle departments because we are just getting a fixed budget. Well, no, you still got to code claims. We still got to collect co-pays. We still have to do quality assessments. But I want to emphasize something really strongly, and I think Eric will help me with this as well too during our discussions, that many hospitals are already at financial risk. The status quo is not risk-free. It is not risk-free. So again, that requires some candid internal thinking, but please recall that many hospitals are already at financial risk. If you all are not familiar with the work that's being done at University of North Carolina, you should become acquainted with it. They are assessing financial distress in critical access hospitals across the country right now. It's exceptional work. But the key take-home point here is the status quo is not risk-free. So let's get back to my questions. If I'm offered a value-based payment contract, should I sign it? Or my corollary is, a value-based payment system is forced upon me. What should I have done to prepare for it? And I want to just add a little bit to the end of this to this corollary. Those on this call are probably not regular readers of the Journal of the American Medical Association, or JAMA. But my hero, Don Berwick, who I introduced you to a little earlier, and Rick Gillifan introduced or wrote a viewpoint in JAMA a few weeks ago that suggested that all healthcare providers in the country should be included in an ACO. All of them. These are two pretty influential individuals. And if they are recommending that, we should be paying attention to what these two individuals are saying. And if Rick Gilfillan and Don Berwick are saying every healthcare provider in the country should be in an ACO, that's my corollary right there. So I got some suggestions for you. First off, remember, value-based payment requires value-based care. So if you want to receive value-based payment, you're going to have to deliver value-based care. And I'd like to direct you to an assessment tool that my team at Rural Health Value and I put together, called the Value-Based Care Assessment Tool. And it will help you assess your organization's current capacity and opportunities to improve your capacity to deliver value-based care. I have several links. I'll kind of pause for a moment here. I have several links in this PowerPoint presentation, and our good folks at the National Health Resource Center will be able to put these together in a PDF and make sure you get those. So I'm going to recommend to you 5 tasks, and we'll go through each one of those: assessing financial risk, engaging physicians, expanding community care coordination, embracing interdependence, and then understanding cultural change. So let me just kind of talk about each of those. So you need to, again, assess the concept of risk. And remember, risk is both upside and downside. And also remember, the status quo is not risk-free. We tend to have, as human beings, a loss aversion. It's an irrational human bias. Let me give you an example. If I ask you for $5 and now I'm going to flip a coin, and each time that coin goes heads, I keep your $5. And if each time that coin goes tails, I give you your $5 back and give you 10 bucks, will you take me up on my offer? Well, you should take me up on my offer. You might not because of loss aversion, but you should, because statistically you should be getting, if we do this an infinite number of times, $2.50 every coin toss. That's an example of loss aversion bias if you wouldn't take that challenge. It's also important to know your fixed and variable cost ratio impact on your ability to profit in a value-based payment environment. Now, we won't go into accounting details here, but this is an important concept. And if you feel a little bit uneasy about understanding fixed and variable costs, talk to your colleagues about it. Email me a question or email Eric a question, but this is a really important concept. And then it requires pro formas and sensitivity analyses. I believe that all hospitals should have pro formas at least 5 years out, and I can tell you really successful ones go farther than that. So we want to understand, based on your best projections, what's going to happen to your profitability in the future. And it requires candid, informed, and honest assessments. And if you'd like a resource for that, Eric primarily, and I think I helped a teeny bit, put together Excel-based pro forma for cost reimbursement in critical access hospitals. So if you want to know what's going to happen, and here's the cool thing about this particular tool, you put in your own variables, how much you think your costs are going to go up per year, how much you think your population, your volumes are going to go up in outpatient or inpatient services. You put them in, see what happens. Next, we need to engage physicians. And I'll pause for a moment. When I say physicians, most of the research on physician engagement has been about physicians. But when I use the word physician, I really mean almost all clinicians. So this includes nurse practitioners, physician assistants, all. But let me just stick with physicians for a moment, simply because that's where the literature goes. So physician engagement is this. It's proactive. This is key. Proactive physician involvement and meaningful physician influence that lead the organization toward a shared vision and a successful future. And I think you need this as hospital leaders. You do. And believe me, having employed physicians does not necessarily mean they're engaged. Let me just tell you a quick anecdote. I was talking to a hospital CEO a few years ago, and he said to me, you know, Clint, those physicians see who signs their paycheck. They'll do what I say. If there's any physicians in this audience, they know how ridiculous that particular comment was. But physician engagement, proactive physician engagement, is a cultural phenomenon. It's how you and your organization behave that then leads to belief systems about the physician's role in the success of the organization. It's a cultural phenomenon. And it really is based on trust. And I wondered at first whether or not trust can actually be measured, but it can. Some kind of more experienced pollers like Gallup and HealthStreams actually can assess trust in an organization. I've got another resource for you that I put together called Physician Engagement, a primer for healthcare leaders. Next, we need to expand this concept of care coordination and expand it. I use the word community very specifically in this. It's more than discharge planning. It's certainly not utilization review. It's trying to get your patients to the right care at the right time at the right place without duplicating. And it must engage community-based organizations, social service organizations, area agencies on aging, Meals on Wheels, transportation agencies. This is how you start thinking about health, not just illness care. We start thinking about how we engage person-centered. Probably better to use health home than medical home now. So the patient-centered medical home is the traditional comment. Those of us who've kind of worked in this space are starting to morph the words to better represent what the PCMH should be doing. And it should be person-centered, not just patients. It should be health, not just medical care. And this requires data analytics. It requires an analysis of where our patients are spending their money and how can spending their insurance money or their money technically, where they're using healthcare resources, and how can we help those patients use healthcare resources more wisely and actually get better care. And Stratus Health, for those of you who are interested in putting together a community-based care coordination system in your hospitals or in your health systems, Stratus Health, the quality improvement organization out of Minnesota, has developed a dynamite toolkit for this. And it's based for organizations that are just starting in this space or already very experienced in it. It can be modified for each. Really, really important. Next, embrace interdependence. And I'm using that word very specifically because I don't think in the future we can do this as isolated, independent healthcare organizations. We in rural are kind of defined by small size and fewer resources, and that's a barrier to participation in some of these value-based care models, at least currently. We do need some economies of scale. Remember, I've mentioned, I think at least a couple of times, we need capacity around population health management. We need capacity around financial management. So we need economies of scale. We need analytic and managerial infrastructure. But as we do that, global budgets especially kind of change the competitive focus. We're no longer competing with our neighbors. In fact, we don't want patients coming to our hospitals. We want them to be healthy. And lest you think that mergers and acquisitions is the only way we get here, please don't think that. Affiliations is much more than mergers and acquisitions. And I'll refer you to an article written by a colleague of ours, Joe Lupica, called Enlightened Interdependence. And lastly, understand culture. We're trying to move healthcare system culture here from thinking about volume to thinking about value, to thinking about sickness to thinking about health. Now, of course, we will always treat the ill, but it becomes a cultural change to move these two needles. And I think we do that through behaviors. And this is kind of, so you can take this for what it's worth because I kind of dreamt this up. But what we do becomes what we believe. So it's personal behaviors. It's the behaviors of the leadership, how we behave. It's governance. How do we set up our balanced scorecards for our boards? Is the first thing that our boards look at is our average daily census, or do they look at community health? And it's organizational behavior. What do our job descriptions look like? What do our performance evaluations look like? What do our compensation systems look like? Do all those things tend to look at volume, or do they look at value? Do they look at sickness? Do they look at health? So this volume to value transition, you'll hear those words a lot. It's an exciting managerial challenge. Is how do we get people doing this culture change? That's exciting, but it tends to alight incentives. And you know what? It's best for what matters. And here's what matters. What matters is that we have kids that grow up in our communities healthy and safe and well-educated, that we have workers who are safe and productive, who come to see you to get back to work, not get out of work. And we have our older population who can retire and age gracefully with safety and security. That's what matters. Here's some more resources for you. And with that, I will stop and turn things over to Terry.
And thank you so much. You always do such a great job breaking this down into kind of understandable components. We had a question about value-based payment versus value-based purchasing. Are they the same thing? It's confusing some folks.
No. So value-based purchasing is a specific Medicare program, value-based purchasing. Value-based payment is much more global. It is not assigned to a specific program or model. It refers instead to payment for one or more of the triple aim, of the three parts of the triple aim. So value-based purchasing is a very specific Medicare program. It applies to PPS hospitals. It does not apply to CAHs. But I can sure understand the confusion. The VPP is the same kind of abbreviation.
Thank you. If you have questions, you can either put them into the chat box or just unmute your line and ask them. I'll give a brief time here to see if anybody has a question. Okay, I'm going to turn things over. Eric Shell is from Stroudwater Associates, and he's had a lot.
Hi.
Yes?
Hi.
Okay. Yeah, go ahead.
Hi. This is Gwendolyn Glover from the Community Champion Program at Greene County Hospital in Utah, Alabama.
Okay, great. Do you
I
have a question?
I was yes, I kind of came in. I wasn't able to get a clear signal with Zoom, so I'm on the phone, and I kind of missed the beginning of the meeting. So the abbreviations was ACO or something like that. I was trying to write as fast as I could. I think it
Well,
was
don't write.
ACO. What's that? Just it was a great introduction that Dr. McKenzie gave. It was great. I really enjoyed that. I just did not catch a little bit of. I don't mean for you to go back, but I think it was something about ACO you were saying.
Yeah, so
What is that?
the whole presentation will be available to you, so you'll catch it. Please don't write anything down while you're driving. But the ACO
No, I'm
stands
at
for.
my desk.
Oh, okay, good. Okay, this ACO stands for Accountable Care Organization, and we won't
Can
go
you
into.
repeat that? I'm sorry. I'm
Sure.
on the phone. I can't hear you. Say
Accountable
that once again.
Accountable Care Organization. So we won't use this time to talk about ACOs in particular, but please refer to the to the whole presentation. It gives a background for you. Go ahead, Terry.
Okay.
Yeah, thanks for your question. Eric
Thank you.
Shell is from Stroudwater Associates, and I'm going to see if Eric has a comment or a question. Eric?
Well, Clint, or Dr. McKenzie, excuse me, spoke a lot around financial risk and the need to do some type of a pro forma or future projection. And I think sitting down with the accountants in the room and putting together, a 5-year plan, as Dr. McKinney mentioned, or even a 10-year plan, is super helpful. The CFO is going to have to sign off on this, and so is your board. And so to look at compare and contrast maintaining the fee-for-service world versus moving into a value-based payment methodology, and building in enough sensitivities so that you can kind of test both models. For the first model, the fee for service, let's make sure that we get our assumptions reasonably accurate. Most folks, when they're looking out into the future, they're saying, boy, we can grow volume by 3%. We're going to get a 3 or 4 or 5% increase from our commercial payers. And with that, in cost-based reimbursement for the critical access hospitals, boy, things look pretty good because our costs are only going to go up 3%. Well, here is the question. Are we really going to generate 3% increase in volume across all service lines? And are we really, in our costs only going up 3%? And I think those are two questions that we have to run some sensitivity on in the fee-for-service mindset. The second is in terms of your value-based payment model and making sure that we understand kind of the revenue inputs and the expense inputs going out some period of time. The one thing I want to make sure that it's important is that when we start looking, for example, at ACOs, accountable care organizations, and Dr. McKinney talked about that opportunity to create shared savings. Shared savings is always a measure of claims, right? Claims. It's the accumulation of claims divided by your population to come up with a per claims spend per population, and that's compared to your benchmark. Well, claims, the only time claims is equal to the variable cost of providing the function relative to the ACO is if the service was provided outside of your own system. In other words, if I sent a patient to a big city hospital for pneumonia, and there's a $5,000 cost associated with it, the cost is equal to the claims cost because that's what the charge is to my ACO. I don't see any dollars. If I'm able to provide that pneumonia patient to in-house, my claims cost, it's still claims cost. So the ACO budget is still kind of agnostic as to where that service is provided. But the thing is, that cash came to me, and my variable costs of producing that service, the true variable costs, are pennies on the dollar. The point I bring this up is because when we start looking at these future pro formas, and especially around maintaining services in-house, there's a real number associated with increasing the amount of services provided locally. And there's a positive financial consequence of doing that. So again, I definitely wanted to bring up this idea of risk. Also, Dr. McKinney talked about how do we look at fee for service? And is it going to be the wave of the future, or is it going to wane? We had a change in administration. Well, just a week ago at the National Association of Accountable Care, the new director of CMMI, Dr. Liz Fowler, she was speaking at the conference, and ultimately some of her comments, I have them here on I copied them down. She said, we need to find a way to bring everyone along. We can't have fee for service remain a comfortable place to stay. In other words, this world of fee for service is not risk-free anymore when you have the head of CMMI ultimately saying, we've got to bring people along by making fee for service uncomfortable. And so I think that's a really important point. And then Dr. McKinney also talked about the challenge of moving folks, your culture, moving folks, the managerial challenge of moving folks from the fee for sick care payment system to a value-based payment model. And I think the biggest challenge, and being an accountant I wanted to be an accountant when I was in 10th grade. So I look at the biggest challenge is the payment system. We've, for 50 years, or however old Dr. McKinney is, we've organized ourselves around the functional imperatives of this fee for service, this fee for sick care payment, which is maximize sick care volume, maximize unit price, and minimize cost. And those things you can all do, as an individual. And so our system has gotten really good at that. When all of a sudden the payment system is starting to move, there's new functional imperatives, and it's around creating health. The problem is our accounting system, which is tied to the current payment system, anything that we do to create health in the short run shows up very poorly on our financial statements. And ultimately, we have to take our financial statements to the board of directors every month and say, hey guys, look, we're doing great in value-based payment, and we're losing our shirts when it comes to the way our financial statements are showing up. And so I would look at that as a clear managerial change. It's almost like we need a second set of books to show some of the positive impact of value-based payment, almost like a shaded number that goes at the bottom line. Now, any GAAP accounting people or generally accepted accounting people are cringing right now and are furious about my statement, but somehow we have to reflect value for value-based payment models that isn't necessarily going to show up today. And so I just wanted to add a little bit of flavor to Dr. McKinney's comments. So I don't know, Terry, if you have anything else, Dr. McKinney, if you have anything else.
Well, let me just jump on your point here. I think what you just said, especially that last part, is we also have to educate our board of directors about this concept as well. And one of the things I can say is our center has put together some leadership materials and video series directed specifically towards educating boards of directors, because you're right, that's one of the big hurdles. And when they see that declining revenue, some of them get extremely concerned about it. So I'd say education would be really important. And then I'd also like to ask Dr. McKinney, you mentioned the physician engagement as being so important, but I keep hearing that this is one of the biggest stumbling blocks to getting a highly functioning accountable care organization. When should physicians be brought into this planning process?
At the beginning. So physicians as a group are relatively perceptive. and if you invite them into a decision-making process after the decision has been made, that's the quickest way to disengage a physician. The other way to disengage a physician is to make a explicit or even implicit promise and then never follow up. So Terry has often told me about an experience that he had speaking to some medical directors for an ACO. And Terry may correct me, but there was 90 to 100 medical directors in that ACO or in that meeting. And they were asked, how many of you were invited into the decision about whether to form or join an ACO at the beginning? And evidently, like 15 hands went up. So again, if you recall my definition of physician engagement, it's proactive. It's proactive. And inviting physicians who will be key to your success in almost any healthcare endeavor, they will be key to your success or key to its failure if you don't engage them well, is really asking for a challenge that you don't need. Now, I'm also the first one to admit that my colleagues, Mary Wakefield, talked about, Clint, you and your frat brothers at the AMA. And I'm going, okay, Mary, I get it. Mary's a nurse. But the point is, I know that physicians are a challenging group to engage, to engage. And I've given talks about physician engagement specifically. We won't go into the details here, but I want to still emphasize and underscore Terry's comment that physician engagement is key to success in value-based care.
And there's so much in it for primary care physicians, Clint, as well. I mean, the primary care physicians take on a whole new importance here, and that's an asset that we have in rural America. I'm going to thank our Dr. McKinney and Eric Schell. We're just about out of time, but thank you so much for being a part of this, guys. And I'm going to turn things over back to Shannon for final comments.
So once again, thank you, Dr. McKinney, for your time today. We also want to thank Eric Schell from Stroudwater and Terry Hill from the Center for an interactive and informational panel discussion.